speaker finished her Bachelor of Science major in Biology from the University of Santo Tomas and her Doctor of Medicine and Surgery from the University of Santo Tomas Faculty of Medicine and Surgery. She had her residency training in obstetrics and gynecology at the Baguio General Hospital and Medical Center and fellowship training in obstetric and gynecologic infections at the UP-PGH. She is a fellow of the Philippine Board of Obstetrical and Gynecological Society, is the current chair of the HIV/AIDS core team at the Baguio General Hospital and Medical Center, where she likewise chairs the research committee. She is now the training officer of the Department of Obstetrics and Gynecology of the Baguio General Hospital and Medical Center. Colleagues, please welcome our speaker for today, speaking on the topic Immunization Recommendations for Pregnant Women, Dr. Maria Lorena L. Santos.
Thank you, Dr. Gallardo. Okay, so I'll be speaking on pregnancy or immunization during pregnancy. Most of my lecture, or most of the content of my lectures, were lifted from these references, primarily that of the Centers for Disease Control and, of course, local guidelines from the Philippine OB/GYN Society. Now, as a general statement, immunization or all women, ideally all women should have had their immunization up to date prior, bago ka mabuntis. Am I right? That's prior to conception. However, why do we have lack or suboptimal yung ano natin our take in the vaccines or immunization is suboptimal. Remember yesterday, one of the discussion was that some believe that tetanus toxoid is actually abortifacient, when in fact it's being given at the barangay health level, at the government hospitals, even endorsed by the WHO. So could that account for the suboptimal vaccine uptake? It may be. Now, let's also take into account that many pregnancies are unplanned. If you're not planning, if you just got pregnant accidentally and all, then nawala na lahat yung plano mo. I'm planning to have my vaccination next week. Then, boom, 2 weeks later, you got pregnant. Na-defer na lahat yung plano mo, right? Okay, so general principles, we'll just review through the general principles. Most of the previous lecturers have given them, but we will just go through them very quickly. Okay, when you say vaccination, this is basically equivalent to a natural infection. It's like you had the disease naturally, and that would be the active immunity. Now, vaccines can be classified as either live attenuated or inactivated. The live attenuated vaccine is the closest that you can get to a natural infection. How many times do we have, or how many times can we have chickenpox? Actually, isang beses lang, right? Because the infection or the immunity that is being produced by the chickenpox infection induces production of memory B cells. So that the next time we get exposed to chickenpox, natandaan na ng katawan natin yon, hence, we will never, succumb to another chickenpox. See, herpes zoster or herpes zoster infection is another story. Because herpes zoster is a reactivation actually of the chickenpox virus, right? They come from the same virus. However, herpes zoster is seen in immunosuppressed patients, the elderly, medyo may edad na, or HIV patients. Nakikita yan, or they usually occur in those patients. Inactivated vaccines, on the other hand, they cannot replicate. They don't have the capacity to replicate. They generally are not as effective as the live vaccines, and they generally require about 3 to 5 doses before they can surmount enough immunity for us. In order for us to be protected fully, we would be requiring about 3 or 4 doses. Some general principles again. The risk for a developing fetus from vaccination of the mother during pregnancy is primarily theoretical. What does this statement mean? Meaning, in all the live vaccines, MMR are the very known given to reproductive age women, measles, mumps, and rubella. Theoretical lang pala eh. Why can't a pregnant woman receive MMR? What that statement means is that by evidence and by observation, ano ba nangyayari? What happens to a pregnant woman who gets infected with chickenpox in the first trimester? The infant develops congenital limb abnormalities and other congenital malformation. So, given a live vaccine, it will mimic the infection of that of the chickenpox. Hence, you will presume that when the baby gets delivered, the baby will also develop those congenital malformation. Same thing with measles. Measles in a non-pregnant is basically of low morbidity, uneventful, diba? When you get tigdas, it's basically uneventful in the adult. However, measles, especially German measles or rubella, in a pregnant woman in the first trimester, you would expect multiple congenital anomalies. What are they? You would have cataract, congenital deafness, even heart abnormalities. So it's like if you give these live vaccines, you will induce the actual infection in the pregnant. So that's what we mean when we say that giving vaccination, especially live vaccination to pregnant women, would cause some risk, but they are only theoretical because you don't intentionally give those live vaccines in a pregnant woman. Okay. Now, there is no evidence as we speak that that inactivated virus, whether bacterial virus or bacterial vaccines, can cause some risk or in the pregnant woman. So you may give them. An example of which is tetanus, right? Okay. And then whether live or inactivated, vaccination of pregnant women should be considered on the basis of risk versus benefit. The question that, or the statement that would summarize this slide is that if I don't receive the vaccine, mamamatay ba ako? Will I die? If I don't receive the vaccine, will the baby die? That's weighing the benefit over the risk. Nakagat ako ng aso, magtatanong, pwede ba akong bakunahan ng anti-rabies? The question is, if you don't get vaccinated with rabies, mamamatay ba ako? Yes. You know, the benefit will outweigh the risk. Same thing with antibiotics, right? You have this life-threatening infection. The drug category or the antibiotic category is category C, meaning studies have been done on that vaccine or on that antibiotic, and in the animal studies that have been done, they have shown that the offspring of those animals showed some congenital malformations. But then, there were no studies done in human. So, still, the benefit of giving the antibiotics or the vaccine for this matter, for our discussion, will benefit if I will receive the immunization. That's how you will summarize this slide. Now, if you will give the passive immunization in the form of immunoglobulin, will there be a risk? Still, there is no known risk that will exist for the fetus if you give passive immunization, especially those with immune globulin preparations. What's the role of an OB? Critical, kasi kami ang nasisisi. Sometimes it's the OB that gets blamed if, say, the baby develops some infection later on in life. Why? Because the mother did not receive the full complement of the immunization or vaccination that adult women ages 15 to 45 years old should receive. So, the role of the obstetrician is very crucial in reducing maternal complication as well as that of the neonatal complication, and of course, ultimately, the burden of disease and transmission of disease. So, napaka-critical ng role ng OBs. I can see that most majority of the women here are in the reproductive age group. Questions have been posed a while ago by the previous speakers. Have you received at least your MMR? I'm sure less than half, or even only a handful of you would have received your MMR. And these are very important. Maiisip nyo na lang to if you do develop rubella or German measles during the time that you are pregnant. I should have had my immunization when I was still not pregnant. Okay? Now, since the discussion for today will be focusing on the immunization that one receives during pregnancy, we will be focusing on these ones. So this is basically a summary of all what we will go through. Hep A, Hep B, can we give? They are inactivated. Yes, you may give. HPV, yes, this is human papillomavirus. It's though inactivated, there are not enough studies done amongst pregnant women that would warrant or that would give us the indication that we can give it during pregnancy. Now, the other is influenza, which is categorized as either inactivated or live attenuated. Of course, the inactivated may be given during pregnancy. The attenuated, the live attenuated, along with the MMR, are contraindicated. Meningococcal, pneumococcal, and are given if indicated, meaning if there's an epidemic going on in your area, then you may receive them. Then we'll go through them. We'll start with Hepa A. Humans are the only known reservoir for hepatitis A, and the transmission is fecal-oral. That's why in those applying for work, in the kitchen, where else? Food handlers, they require Hep A as a part of the testing, right? Along with the fecalysis or stool exam. Because the route of transmission is that of fecal-oral. There's no temporal pattern noted or observed in Hepa A. Communicability is that of 2 weeks before, 1 week before onset. Mostly, protean ang manifestation ng Hep A. When you say protean, it could be the flu-like. Myalgia, fever, malaise, it's non-specific. Hence, you can suspect it or you can even mistake it for some other illnesses. Hep A is a killed virus, okay? And who are the ones who would specially need Hep A vaccination? These are the person with clotting factor disorders. CLD is chronic liver disease. MSM, I'm using abbreviations that are internationally accepted. MSM are males having sex with males. It used to be known as men having sex with men, but now they changed it to males having sex with males. IDU, injecting drug users, now it's changed to PWID, people who inject drugs. Okay, and then occupational risks, as I've said, if you are food handlers, and for purposes of travel, if you're traveling to a place very endemic or there's high incidence of Hep A, you might want to receive Hep A vaccine prior to your travel. There are 2 doses given at 0, and then the second dose is given at either 6 or 12 months. Now, the safety of Hep A vaccination during pregnancy has not been determined. But again, theoretically, since Hep A is a killed virus, then you don't run the risk of what? Harming the fetus. So by all means, if you're at risk or susceptible to getting Hep A, get the immunization or get the vaccination. Hep B. Between HIV and Hep B, did you know that Hep B can survive in inanimate surfaces like tables for as long as hours or days even? Not like HIV. They need a white blood cell to multiply. So all the stigma and discrimination against HIV, let's try to hold them. Okay? Mas mahawa pa tayo sa isang hepatitis B infected patient than that of the HIV. Okay? Hep B, humans are the only known host and they may retain infectivity for more than 7 days at room temperature. Again, even in inanimate objects like that of the table. There are more than about 350 million chronically infected worldwide, and it's a known human carcinogen. Why? Because it's responsible to about 80% of cases of liver cancer or hepatocellular carcinoma. Incubation period, average of 90 days, meaning from the time you are exposed to the time that you get symptomatic, it gets about 90 days. Okay? Non-specific din or protean din yung kanyang manifestations, malaise, fever, headache, myalgia. The sad part is that at least about 64% of those infected with Hep B are actually asymptomatic. So you don't know that you're actually transmitting the hepatitis virus to someone else. We all know that there are only 3 routes of transmission of Hep B. What are they? Mother to child, blood transfusion, sexual, right? Same with HIV. There are only 3 routes, major routes by which you can acquire hepatitis B infection. Complications, if ever it goes undetected or untreated, unmanaged, fulminant hepatitis, cirrhosis, worst case scenario, of course, death after a long battle with hepatocellular carcinoma. Reservoir, humans, bloodborne, subclinical, meaning asymptomatic. Those are the subclinical cases. However, the sad part is that they can still transmit the virus. Communicability about 1 to 2 months before and after the onset of symptoms, and there could be chronic carriers without them producing any symptoms. Look at this table. This is what will happen to the baby or to the infant when the mother is infected with hepatitis B. If the mother, routine in the prenatal checkup is what? Hepatitis B surface antigen screening. It's a routine laboratory workup along with RPR or rapid plasma reagent in detecting syphilis, along of course with your CBC and then your urine gram stain. Now, if the mother is HBsAg positive, you get the profile. You get especially the hepatitis B E antigen. HBe is the measure of someone's infectivity. If positive ka for HBe, you could be potentially highly infectious. If on the other hand, you already have anti-HBe, your infectivity is kind of low compared to someone who doesn't have an anti-HBe pa. So if the mother is HBe and HBsAg positive, you run the risk of as high as 90% of giving the infant chronic hepatitis B infection. And that's so sad, right? If, however, na-detect ang infection, hepatitis B infection ng mother, the baby, the infant could receive immediate vaccination, active and passive immunization within 12 hours of life. And if the baby or the infant does receive the immunization within 12 hours of life, the risk of having chronic hepatitis B infection is lowered to as low as 10 to 15%. There's still the risk, pero lower at least. You can live with that, possibly. Diba? I can live with 10 to 15% chance than that of the 90%. If, however, the mother is HBe negative and hepatitis B surface antigen positive, there's still a risk, pero lower lang, less than 5% risk of the baby having a chronic hepatitis B infection. If, however, the infant receives the active and passive immunization within 12 hours of life, still there's the risk, pero much lower at less than 1%. Of course, it's a different story if you're not infected with either HBe or hepatitis B surface antigen. You don't stop there. That means the mother is non-infected and possibly still hindi pa siya nababakunahan. So you might as well want to give the mother the vaccination or immunization even while pregnant. Okay? It's a recombinant vaccine given in 3 doses. 0 at the second dose is at 1 to 2 months, and then the third dose is in the 4th to 6th month. The vaccine, as mentioned in the previous lecture, they do not contain they contain non-infectious materials, HBsAg particles, and therefore it's assumed that they should cause no risk to the fetus. However, there's limited data indicate no apparent risk or adverse events to developing fetus when the Hep B vaccine is administered during pregnancy. Okay? Who are the women who should receive Hep B vaccine most specially? There are a list of high-risk patients who should specially receive the Hep B vaccine. And these are the women who have had more than one sexual partner during the past 6 months, more than one sexual partner, I think that's what we label promiscuous, has been evaluated or been treated for STD. In your routine diagnostics for the pregnant woman, you saw you were able to diagnose what? Syphilis, what else? Gonorrhea, chlamydia, then by all means run the test for hepatitis B, and even if she's non-reactive, meaning still luckily non-infected, give the immunization. Recent or current injecting drug use, having had an HBsAg positive sex partner. So if your partner is HBsAg positive, might want to receive the immunization. Now, I'm sure everybody will agree with me that hepatitis B infection during affecting pregnant women may result in adverse severe disease for the mother and chronic infection for the newborn. Therefore, neither pregnancy nor lactation should be considered a contraindication for vaccinating women. This is what we should do when we catch a pregnant woman, especially those working the health center. You run hepatitis B surface antigen screening, okay? If the mother is negative, you initiate maternal hepatitis B vaccination series. Again, it's a recombinant killed virus with non-infectious particles. Give the vaccination. To the infant, you initiate the vaccination series at birth, as per provided by the EPI. If the mother, however, is infected, as shown by the reactive HBsAg antigen, you confirm it. Don't give the diagnosis right away. You run the HEPA panel, okay? If na-confirm siya, the infant, the pediatricians or the pedia people should be informed that the mother is HBsAg infected, then hepatitis B infected, then the infant should receive immunoglobulin, and you should initiate the immunization right away, the active vaccination right away. This is what we do kung infected the mother. At birth, you give the first dose of the vaccine and as well as that of the immunoglobulin within 12 hours of life. And then you give the second and third dose as provided in the guidelines, which is 0, 1, 6. Okay? Now, immunization or vaccination is just one of the strategies by which we can eliminate hepatitis B. And actually, it can start with, how I see this slide is that it should start from here, from the bottom. Vaccination of adults at high-risk group, right? Actually, hindi high-risk vaccination of all of us. Because if all of us are vaccinated, and we should admit that we are in a reproductive age group, then the chances of us eliminating hepatitis B transmission to the infant is actually what? Nananalify siya, nanenegate siya. So, from the bottom ang i-start ko, vaccination of adults. Once we're immunized or vaccinated with Hep B, then we can pass the antibodies to our children, to our future children, and then may eliminate na ang hepatitis B sa atin, right? So that's, again, immunization is just one strategy by which we can eliminate Hep B. What are the other strategies? Single sexual partner. Kasi what? You get it if you have multiple sexual partners. What? Preventing injecting drug use. And eliminating also lifestyles that would give us or that would lead us to having chronic liver infection, hence making us susceptible to Hep B. So, immunization or vaccination is just one step. There are still other steps to be undertaken. HPV, human papillomavirus, is one subject matter that's close to me because cervical cancer is the second leading cause of death amongst women. Second leading death, but the sad story is that it is preventable. If I will ask for a raise of hands, how many of us have had pap smear at least? I'm sure only a handful. Bakit po hindi po kayo nagpa-pap smear? Masakit po eh. Sino nagsabi sa inyo? Yung kapitbahay. You know, by word of mouth. You get scared by only by the word of your by the word of your kapitbahay. Hence, you will not subject yourself to a simple pap smear, which is one step in what? Screening for cervical cancer. And human papilloma virus is the known causative agent for cervical cancer, along with the other HPV-related diseases. Like what? Anogenital warts, recurrent respiratory papillomatosis, and some cancers of the anus. Babae at lalaki may anus, so we both are at risk for having the HPV. Of course, babae lang ang may cervix, so cervical cancer can be seen in women also, as well as that of the vagina. However, head and neck is something that can be seen or common amongst men and women who may be infected with human papilloma virus. HPV vaccine efficacy. This was approved by the FDA in 2005. The first one approved by the FDA here in the Philippines is the quadrivalent vaccine, Gardasil, 6, 11, 16, and 18. It shows 100% efficacy against the anogenital warts. For the 16 and 18, as high as 95 to 98% efficacy, meaning it can prevent cervical cancer in 95 to 98%. But for anogenital warts, it's 100% protection. Now, no evidence of efficacy against disease caused by vaccine types of which participants were infected at the time of vaccination. Nagka-warts na po ako eh. Can I still receive the vaccine? What's the answer? Yes, you may still receive. Nagka-infection na nga ako eh. Nagka-genital warts na nga ako eh. What merit will I still get? Remember, the vaccine offers protection against 6, 11, 16, and 18, right? By some fluke or by some unfortunate situation, you get infected with 6. Then you can still get protected with what? 11, 16, and 18. So you can still benefit in receiving the vaccination even if you've been infected with genital warts. But ideally kasi, you give it if you are HPV naive, meaning even prior to your sexual debut. Because acquisition of the human papilloma virus is mainly usually through sexual intercourse. Why did I say mainly or usually? There have been anecdotal reports that you can get HPV transmission through what? Fomites. But as I've said, anecdotal lang siya. Okay? Now, vaccination is given for women, males and females aged 11 to 12 years, but you can start as young as 9 years old. Catch-up is given at ages 13 to 26 years old. Again, ideally given before sexual debut or before sexual activity. Quadrivalent HPV is not recommended for use in pregnancy, and although in the multi-center studies done, of which Philippines is included, there were some who got pregnant while they were included in the study. And then, when they were followed up, no fetuses were observed to have some congenital abnormalities, even if they were able to receive the HPV vaccine during the time that they did not know that they were pregnant. Okay? What happens? Doktora, 0 na and then 9 months na yung sumunod. According to reports, you do not need to reinitiate the series. Okay? You do not need to reinitiate the series. You give it and then you receive it on the 9th month, and then the 3rd dose will be given 4 months after the 2nd dose. You resume it. Okay? Influenza, much has been said about influenza. Humans are the known reservoir, respiratory route of transmission. In the Western countries, December to March, ang peak, but I'll show you a little later on the RITM surveillance, wherein they gave us the peak season, flu season in the Philippines. Communicability is about 1 day before to 5 days after the onset of the symptoms. Incubation period, about 2 days, that's the range. Again, protein manifestations, fever, myalgia, sore throat, and unproductive cough. Pneumonia can be, influenza has a list of complications. Pneumonia is one of them, Reye syndrome, myocarditis, and worst case scenario, death, occurring in about 1 per 1,000 cases. Vaccines are available in two forms, inactivated and the live attenuated. Again, the live attenuated is contraindicated during pregnancy. The inactivated, on the other hand, is given intramuscularly. It's a killed virus and it's given in a dose annually. Dr. Coronel has informed us that for 2013, the Southern Hemisphere is the strain that will be given to all of us. The strain that we may receive, right, as protection against influenza. Again, based on the RITMDOH surveillance, influenza virus surveillance, which was done in 98 to 2003, they observed that the flu season in the Philippines is actually from July to November. If the flu season in the Philippines is from July to November, then we should receive what? Our immunization from February to June before the onset of the flu season. November, we'll be receiving the 2013 by next year. Pregnant women are special cases of influenza cases. During the height of the H1N1, the worst cases of those infected with H1N1 are actually the pregnant women. They're the ones ridden with the highest morbidity and even the highest mortality. In Baguio General Hospital, we have 1 documented death secondary to H1N1, okay? And another 2 whom we were able to catch at an early stage, hence we were able to give oseltamivir to them. Again, it's a category C drug, but it may mean the death of the mother, even the infant. They received the oseltamivir, hence they were able to deliver or carry the pregnancy to term and delivered uneventful. So, why? Pregnancy kasi mababa resistensya. The pregnant women are immunocompromised. You have an invader in your womb. You have a foreigner. You have someone in your womb. Dapat hindi i-reject ng katawan mo, kahit na human being din siya, kahit tao rin siya, of the same species, we must not reject that invader in our womb. Okay? Hence, immunocompromised tayo. If mataas masyado resistensya natin, we run the risk of rejecting that temporary inhabitant in our womb. Okay? That's why pregnancy is temporarily immunocompromised state. Hence, putting her at risk for acquiring influenza higher than those of the non-pregnant. So, if the pregnant woman is at risk for developing or acquiring the influenza, by all means, give the trivalent inactivated vaccine, especially during the influenza season. So you may give, okay? The live attenuated influenza vaccine should not be given to women because they are live. MMR, live vaccine, these are live virus vaccines, measles, mumps, rubella. They are given in either 1 or 2 doses. It should not be administered to women known to be pregnant. I explained this a while ago. Live vaccines are the ones closest that mimics a natural infection. So imagine if a pregnant woman would have measles, especially in the first trimester, mumps or rubella, which are live viruses, then imagine that if you will give that live vaccine. You expect the same effect if you had the natural infection once the baby is born. And you wouldn't want that. Okay? This is by history. I will just mention it. Sometime 1971 to 1989, they kept a registry of vaccine in women, pregnancy registry. And amongst those that were inadvertently given was rubella. So in those pregnancy registry from 1971 to 1989, luckily for them, none of them, or only about of the 226 women who received the vaccine, none of them actually developed congenital rubella syndrome. So lucky for them. But still, you don't give rubella if in a pregnant woman. Tetanus diphtheria, much has been said about this, again, by the prior speakers. Tetanus is caused by infection of Clostridium tetani. Actually, napaka-useful nito sa cosmetic, di ba? Pag pinapatetano kasi tayo, di ba? Naninigas tayo. And that's what it does in derma. Pinapatigas na kaya hindi na sila nagro-wrinkles. And that's what it does also to us sa katawan natin. Because they block the neurotransmitter that lead to unopposed muscle contraction and spasm. Its efficacy is approximately 100% for about 10 years, hence the rationale of booster every 10 years. TD is indicated routinely for pregnant women, and that's according to the Centers for Disease Control. Again, dissipating the rumors, the belief that it is abortifacient. If you do have some issues regarding tetanus toxoid, then by all means give it after 20 weeks. Okay? If you have reservations for that. Previously vaccinated women who have not received the TD vaccination within the last 10 years should receive the booster dose. If, however, you haven't received it, you give it 2 doses separated by 4 weeks during pregnancy, and then the third dose is given 6 months postpartum, pagkapanganak. So the first dose in practice, I give it at 20 weeks, and then the second dose is given at 24 weeks, and then the third dose is given 6 months postpartum. That's good enough. 20, 24, and then postpartum, 6 months. If you're afraid of giving it below 20 weeks. Pregnancy is not a contraindication for use in tetanus, diphtheria, and acellular pertussis. However, data on the safety, immunogenicity, and outcomes on those bundled with acellular pertussis are still not available. So if you can avoid acellular pertussis, avoid it. Okay? But if your area is highly endemic for pertussis, you may receive it. Because if the mother will receive the acellular pertussis bundled with the tetanus and diphtheria, you will pass the antibody to the child, hence lowering the risk of the child acquiring pertussis. When was the last pertussis in our country? None? Wala. Okay. Then varicella, chickenpox. Deadly, especially if it infects pregnant women in the first trimester. If the pregnant woman is already on her 28th week onwards, or even 20 weeks onwards, nil, halos wala ng epekto sa bata. Okay? So it's only in the first 13 weeks siya deadly. But beyond that, from 14 to 20 weeks, there's still chances of the baby acquiring congenital varicella syndrome, but only to as low as less than about 5 to 10%. More than 20 weeks, halos nil na or negative na yung effect. Okay? Newborns with maternal rash onset within 5 days and after 48 hours. What does this mean? I'm about 40 weeks. I'm due to deliver anytime. Nagka-chickenpox ako. Okay? What will happen? If I deliver right away, nagkaroon ako ng rashes ngayon, nanganak ako mamayang gabi, magkakaroon possibly ng congenital varicella or ng chickenpox yung bata. Right? Okay. So what do you do? If nagka-rash ang mommy, you did an IE, and the mother is still about 1 to 2 centimeters, that's still a long, long way. You try to delay the delivery as long as possible, even as long as 7 days. Why? If the mother is infected with the chickenpox, the mother will eventually develop antibodies. Those antibodies will be passed on to the fetus. Hence, the fetus is already protected. So, don't expedite the delivery. You delay it as long as possible. Yes? That's what we mean. That's how we prevent varicella, infants from developing varicella after being born. Okay? Congenital varicella is a different story because, those pregnant women who, who develop chickenpox in the first trimester, they run the risk of their children developing congenital varicella syndrome, and those would include limb scarring, low birth weight, neurologic deficits. It's a live virus vaccine given in 2 doses at 0 and then 4 to 8 weeks or 1 month later. if you receive the first dose of vaccine, you should not get pregnant in at least 28 days before receiving the second dose. Okay? 28 days. If the mother is susceptible or is exposed to someone who has chickenpox, you may give varicella zoster immunoglobulin. Okay? It's safe to be given for pregnant women. It will activate your antibody production, although not sustained, but it will pass on, the antibody will be passed on to the child, hence you don't run the risk of developing congenital varicella. Immunization for women, last few slides, I just want to share to you the immunization being recommended by the Philippine Obstetrical and Gynecological Society, or POGS. Now, pangit ng slide, in-scan ko lang siya. But anyway, these are the immunizations or vaccinations that a woman should be receiving, a pregnant woman should have received. Even I cannot see the ano. Okay? Gagayad ko na lang kayo. This is tetanus, diphtheria, and pertussis. You may receive it. Human papilloma virus, contraindicated. Measles, mumps, rubella, contraindicated. Influenza, if this is contraindicated, ito na yun, measles, mumps, rubella. Influenza, for pregnant women who will be in their second or third trimester, you may give the influenza vaccine. However, even if you are in your first trimester and if you are very high risk of acquiring the influenza, even if first time, ibigay mo yung immunization or vaccination. Pneumococcal, polysaccharide, it says here, no recommendation, actually. No recommendation, that means, But a pregnant woman is at risk for developing pneumonia, especially from 28 weeks onwards. Makikita niyo yan sa mga buntis, those working the rural health unit. Pansinin niyo, 26 to 28 weeks onward, marami silang nagko-complain ng ubot sipon. Hence, you may give pneumococcal polysaccharide vaccine in pregnant women who are developing really severe cases of pneumonia. Okay, and then this is Hep B, you may give. This is good to go. And then for meningococcal, no recommendation, but if the place is endemic for meningococcemia, you may give meningococcal. Again, if you don't receive MMR, these are the risks na makikita sa pregnant women and those for the infant. These are sad stories because you've been wanting to get pregnant for those with planned pregnancies, and yet they will develop these morbidities, abortion rates, and even some congenital malformalities if you acquire the infection during pregnancy. Okay? Others, travel, right? You may give what? Anthrax, if low risk of exposure, and then meningococcal, again, may be used if otherwise indicated. Rabies, smallpox, post-exposure only, but not for pre-exposure. That's the slide, Rhoda. Next lecture.
You can all answer that. You don't have to ask, as Dr. Lori has mentioned, your kapitbahay. Our next speaker unfortunately couldn't make it today because of some unforeseen circumstances, but delivering her lecture is an equally competent infectious disease specialist who I am privileged to introduce. She is a graduate of Doctor of Medicine at the UERM MMC and completed her residency training in pediatric medicine at the University of the Philippines, Philippine General Hospital Department of Pediatrics. She then underwent fellowship training in pediatric infectious diseases at the UP PGH section of infectious diseases. She had her rotation as an exchange student for research at the Albert Einstein College of Medicine, Montefiore Medical Center of Yeshiva University, Bronx, New York, USA, in the Department of Pediatric Infectious Diseases, and took an advanced course in vaccinology in Asia Pacific at the International Vaccine Institute in Seoul, Korea. She's a clinical associate professor and consultant in ambulatory pediatrics and the infectious and tropical diseases section of the Department of Pediatrics of the University of the Philippines College of Medicine, Philippine General Hospital. She's currently a medical affairs manager for vaccines at GlaxoSmithKline Incorporated Philippines, a fellow of the Philippine Pediatric Society, a fellow of the Pediatric Infectious Disease Society of the Philippines, and a founding member of the Philippine Foundation for Vaccination. Ladies and gentlemen, to speak on new vaccines on the horizon, please welcome Dr. Marimel Reyes Pagkatipunan.
Good morning po sa inyong lahat. Morning. So I hope you had your break already and you are now preparing for lunch. Okay, so for this morning, because I will be here for the rest of the afternoon, so please prepare yourselves for me. Okay, so this first lecture will be on the new vaccines on the horizon. We know that in the future, we will see more and more vaccines that will be available locally. Okay. So far, we know that the vaccines has given us the benefit for, unlike the other modalities that we have now. So like with the exception of safe water, we know that with no other modality, not even antibiotics, has had such a major effect on mortality reduction than the vaccines. So I know that we have seen this before, that globally, worldwide, every year 3 million deaths are prevented and 750,000 children are saved from disabilities from vaccines. How many among you have seen polio victims now less than 5 years of age? Sino na ho nakakita pa? Wala? Wala? Okay. Very good, kasi dapat reportable yon, di ba? So now that in the Philippines, we now are seeing the effect of vaccination, that we are now eradicating a disease. And we know that the impact of vaccination, we know that the disease effect is more than the vaccine, that the vaccine can prevent. So an example of this, the newer ones are the pneumococcal disease that can lead to threatening diseases such as pneumonia, rotavirus disease, rotavirus gastroenteritis, and then the influenza. But the vaccine has given this, has prevented so many deaths, and even decline in hospitalization. So now, we say that the vaccines have the power not only to save, but also to transform lives. That is, we give the children the chance to grow up healthy and then be able to go to school and improve their prospects. Okay. So our vaccines journey continues. Okay. As Bill Gates has said, that any major advance in human condition would requires resolve and courageous leadership. We are so close, but we have to finish the last leg of the journey. Bill Gates has a very good impact on not only on the support for the vaccines, but for the development of new vaccines. Okay. So we know that despite the availability of all these vaccines that we have now, no, against infections, children under 5 still continue to die from communicable diseases. Why? What are the other communicable diseases that we have? It's not only the viruses, not only the bacteria, but we also have parasites. What is the example of the parasite? Okay, and vector-borne. Okay, now we have found that the vaccines is the most cost-effective tool, and the research and development of these new vaccines would continue to better immunization programs and reduce the childhood mortality. So, what have we now? No? What are the progresses in our immunization? The DPT-3 is on track to reach the goal of 90% coverage. Okay, but there are some difficulties in some Southeast Asian countries. Okay, the HIV introduction has been increased. In your area, meron na ho ba kayong HIV coverage? Yes? Sa inyong health centers? Ano ang available sa inyo? It's now available in the 5-in-1 vaccine in the health centers. Okay. And there are also advances, no, in financial sustainability. We have the Gavi, no, but Philippines is not Gavi eligible yet. No? And then the new vaccines are in the pipeline. Okay. So we would like to make this more appealing, that scientific knowledge and development of these new technologies have accelerated the vaccine development. We have now more new vaccines and more clinical trials planned. And this would really increase the global impetus on child survival. Okay. So, among the new vaccines, what are the vaccines that you want to be available soon? Huh? That you know. Dengue pa rin? Okay. Sige, let's see what are the new vaccines that are in the pipeline. The first one that we can talk about is on the HIV vaccine. Although in the Philippines now, there's a rise, no, on the incidence of HIV. So there are 2 AIDS vaccine candidates. When we say phase 3 clinical trials, it's undergoing the testing for more subjects. Okay? But it is not yet licensed or being marketed. Okay? So, yung mga terms ho dyan, na nababasa mo dyan, these are the antigens that they are using. We would like to have this disclaimer that there may be some changes depending on the results of these clinical trials. As you know, there may be some, as we go through the phases of clinical trials, there will be some effects. No, maybe very good effect, or sometimes it may not reach the desired outcome. So there may be some changes. But then again, in a few years, we might see these vaccines coming out in the market. Okay, so there's the Alvac vector vaccine from Sanofi Pasteur, and this is still undergoing testing, but at least we are now in the phase 3. Avian influenza vaccine is more focused on the H5N1 pandemic influenza vaccine. We want it adjuvanted, no? It contains the split or subunit type with oil in water adjuvants. The impact of this adjuvant in a pandemic vaccine is that it is more antigen sparing, meaning you just put a lower antigen content and add the adjuvant, so that if you develop, because this is like a pandemic vaccine, you need more supply so that you can have more or develop more vaccines. Okay. So it also primes the body for an anamnestic response, and it would enhance the breadth of vaccine-elicited antibody protection. Okay. The other novel vaccines under development for avian influenza vaccine are the following. And the vector vaccines are the more promising one for longer-term development, and also the live attenuated avian influenza vaccine. It's a promising candidate. Again, these are all promising candidates. For TB, there's actually, in the pipeline, there's actually a new TB vaccine. We know that what is the available vaccine that we have for TB now? Your BCG, no? But the problem with BCG, it does not protect to your pulmonary, okay, TB. And also, this TB vaccine would unlikely be used as a standalone. So it will be part of the comprehensive TB control approach. Okay, so the TB development, TB vaccines that are in development are your subunit vaccines with add-ons or boosters to your neonatal BCG. Again, we don't know yet what will be the recommendation for this, but based on the design, it is as an add-on or a booster for your BCG. It may be administered together with your BCG or the early booster immunization, or a few weeks or a few months after the BCG vaccination, or as your late booster type to be given later in childhood or early adolescence. The viral vector TB vaccine is a live recombinant vaccine based on the use of the viral vectors. Okay? And these are the candidates for that. These new live vaccines are genetically modified BCG strains. So very new because of the use of new technology. And may have some ethical issues due to the risk of vaccinating your immunocompromised individuals. The new vaccine for Gavi priority diseases, which means, because you know that the Gavi eligible countries, they are the ones, the countries that are the poor countries, that are considered to be, they will give the funding for vaccination, universal mass vaccination. And one of the priority disease for Gavi is the meningococcal A and the Group B meningococcal vaccine. Masasagot ho yung isang tanong dito dun sa question kanina. Do you want the answer? Ano yung walang meningococcal? Okay, so for meningococcal A, it will be a public-private partnership between WHO, PATH, the Bill and Melinda Gates Foundation, and the other malaria vaccine project. And the Group A meningococcal conjugate vaccine would be for the health authorities, yung mga African countries. Okay. Because it is a conjugate vaccine, it would provide long-term protection for children less than 1 year of age. For the Group B meningococcal vaccine, which is not available, I'm giving the answer, is an outer membrane protein that is being used. It is non-valent vaccine with a 9,4A antigen, so they use the other antigens. And it is a novel recombinant OMV vaccine. Okay. We have heard yesterday about the candidate dengue vaccine from Sanofi Pasteur. So other companies also are in the development of dengue vaccines, but I will not elaborate on this. And this is just the differences on the antigens, and depending on the adjuvants that they will be using for the dengue vaccines. Now, there are also now therapeutic vaccines. What we have now in our recommendation or locally available vaccines are all prophylactic vaccine. Meaning, ano yung prophylaxis or prophylactic vaccines? They are being given so that you will prevent you from having the disease. Now, what are therapeutic vaccines? So these are vaccines to fight chronic viral infections and other non-communicable diseases. So this is another strategy, no, that we can use the vaccine. And these chronic diseases have a major public health impact globally, like your chronic viral infections. Your hepatitis B vaccine available is a prophylactic vaccine. But because we have chronic viral infections or chronic hepatitis B, therapeutic vaccines can be used for that. Okay. Also for cancer, Alzheimer's disease, nicotine addiction, and atherosclerosis. Diba, very promising. Gusto niyo ba yan, yung therapeutic vaccines? No, actually, that is very exciting. No? And there are also vaccines, no, against nosocomial infections. Sa PGH4, napakarami naming nosocomial infections. So if a child or if a patient can be given a vaccine to prevent a nosocomial infection, di ba wonderful yun? Okay? So the infectious agents encountered in your hospital environment, the most common is your staph, also your pseudomonas, your gram-negatives. And staph aureus is also notorious with an increasing antibiotic resistance. Thus, we are really very excited about this. The iron surface determinant B is a protein expressed on the bacterial cell surface during the growth of the bacteria. So that may be used as your antigen for your vaccines against your nosocomial infections. Malaria vaccine. How many of you wants the malaria vaccine also? Diba? Kahit na, actually hindi na sa Palawan lang ang, diba, endemic for malaria. Okay, this is a GSK vaccine, the RTS is AS01, this is an adjuvanted vaccine of Plasmodium falciparum malaria vaccine and will be available in 3 years. So malapit na ho. And the hybrid construct of the Hep B surface antigen was fused with the recombinant antigen derived from the yung parasite. Okay? So this project actually is in public-private partnership of PATH, Malaria Vaccine Initiative, which is also by Bill and Melinda Gates and the GSK. So interim results are really very promising. Okay. Just some words on innovative adjuvants. So we have learned that adjuvant systems are specific combinations of your individual adjuvants tailored, or very specific to elicit the most appropriate immune response to your specific antigen and to the population. Now, the synergy of your adjuvant system with the antigen within the vaccine will optimize the interaction of the vaccine with your immune system. So it will give you more robust and prolonged response, And the right combination of the antigen and the adjuvant system can actually help your body mobilize the most effective immunological pathway, which is designed to provide the enhanced protection against that specific disease and in specific targeted population. Okay. So what vaccines will have these innovative adjuvants? The malaria, as I have said, would have the AS01 adjuvant. And the flu vaccines that are some examples, because in the flu vaccines, because we know that in the elderly population, they do not respond very well with your regular flu vaccine. So putting an adjuvant to the antigen would actually boost the system of your elderly. Okay? So beyond prevention, the adjuvant system technology is an integral part of a breakthrough also for your antigen-specific cancer immunotherapeutics. We have the ASCII, or these are the therapeutic vaccines for cancer. Okay. And we are using the adjuvant system for that. Okay, I would just like to show, napakaliit ho, no? Kasi actually these are in the pipeline, so which means that they are all still undergoing the clinical trials, no? As you can see, medyo maliit nga lang ho. Novartis will have many vaccines available in the future for flu, for men, ACWY, Japanese encephalitis, in clinical trial also. Okay. And also the GSK, no, we have new vaccines under development also for your cytomegaloviruses, no, and the other combination vaccines. Also, Sanofi Pasteur has 13 vaccines in development, and these are also promising for us. Okay. So globally, the potential of vaccines, these simple, low-cost tools can save the lives of an estimated of 1.4 million children each year. And it will then prevent thousands more from paralysis and disability. Thus, we are still moving towards the development of these vaccines, because we know that vaccines are unquestionably one of the most cost-effective public health measures available. And it is important for international agencies, governments, I know you are a part of this, and health policymakers to keep this preventive measure in the spotlight. That's why PFB is here for you to support all of these endeavors. So with that, we are really hoping, so the future is very bright. Our vaccine recommendation will be filled with more and more of these new vaccines. Thank you very much.
We'll just give you a few minutes to make your questions. This is the question and answer portion. But before that, I would like to introduce the other member of the panel, and because all the rest were introduced earlier. So she is a renowned pediatrician and infectious disease specialist. She graduated cum laude BS in zoology at the University of the Philippines in Diliman. She had her Doctor of Medicine at the UP College of Medicine. She had residency training in pediatrics at the UP College of Medicine at the Philippine General Hospital. She had her fellowship training in infectious disease at the UP College of Medicine, Philippine General Hospital, and at the Research Institute for Tropical Medicine. She finished her clinical and laboratory course in medical mycology at the UST Department of Medicine. She underwent fellowship training at the Fogarty International Training and Research Fellowship in HIV/AIDS at the Brown University, Providence, Rhode Island, USA. She had her Master of Science in Clinical Epidemiology at the College of Medicine, University of the Philippines, Manila, last 2010. She attended the 11th Advanced Vaccinology course in France. Sorry, I cannot pronounce this. Last May 10 to 21. She is an associate professor in pediatrics at the UP College of Medicine. She is a faculty section of infectious and tropical diseases in pediatrics at the Department of Pediatrics at UP-PGH. She is a fellow of the Philippine Pediatric Society and Pediatric Infectious Disease Society of the Philippines. So, let me call them all up here. For panel 1, please welcome her. She is Dr. Maria Lisa Antoinette M. Gonzalez. So may I call them all upstage. For panel 1, to answer your questions for vaccines for children, Our speakers or those who will take care of your questions would be Dr. Cynthia A. Aguirre and Dr. Maria Lisa N. Gonzalez. And for panel 2, to answer your questions for vaccines for adults, may we call up Dr. Remedios F. Coronel and Dr. Cecilia S. Montalban. And for panel 3, for new vaccines is our speaker a while ago, Dr. Marimel R. Pagkatipunan. And this part of our morning section would be facilitated by our very own Dr. Lulu C. Bravo.
Is, will you have the same immunologic response if the vaccine was not given by the recommended route, IM instead of SQ? Do you have? So who'd like to answer that for the adult and the children? Dr. Chet. Actually, I'd like Dr. Chet because she has not spoken first, no? Dr. Chet would like to say, answer the first question. Will you have the same response kung nagkamali sila ng ruta ng bigay instead of IM naging sub-Q?
Akala ko, ano lang, magpapapicture lang ako dito.
No, Chet is our vaccine expert and part of the chair of the immunization committee sa PPS.
Okay. Actually, if the recommendation is for IM, the major reason is because some of these vaccines have adjuvants. And if you give it sub-Q, that's where you're going to have a problem. So you might develop abscess or some local site reactions. So if it is stated that the vaccine should be given as IM, it should definitely be given as IM. Now the question is for vaccines that should be given as subcutaneous. These are usually your live vaccines, like measles, MMR, varicella. Some of these vaccines, you will note in the product insert, can be given either as sub-Q or IM, so it really doesn't matter. I think most of the studies, although some would argue that the reason why these are recommended as sub-Q because the clinical trials have utilized or administered these vaccines as sub-Q and they have no data whether it will have the same immunogenicity if you give it as IM. But personally, I feel that if it is stated that it should be given as sub-Q but you accidentally gave it as IM, I don't think it should matter and there's no reason for you to repeat the dose. So that's my personal idea.
In adults, in terms of the rabies vaccine, it's very important that, well, of course, we give the vaccine either IM or intradermal. It's important the intradermal should be given really intradermal and not sub-Q because the absorption of the vaccine will differ. It has been shown in several studies that you had better absorption of the vaccine using it intradermal rather than subcutaneous. So, hindi pwede ma-interchange yun. And you know that we're talking of a life-threatening disease, so we should give it the right way. ID or IM only.
With regards to question, that question has been asked a lot. And if you go to the website of ACIP, among the most frequently asked questions, it's one of the most common questions being asked if you gave it by the wrong route. And the answer of ACIP is that you don't need to repeat the dose. If you give an IM, a sub-Q or a sub-Q IM, you don't really need to repeat the dose. You just have to continue with the immunization.
Okay, just...
If it's, but if it's IM, make sure it's IM. Hindi pwedeng sub-Q, hindi pwedeng intradermal. Overall, even DPT, don't give it sub-Q. Kasi magkakaproblema kayo. Pero pag sub-Q, okay na i-IM.
Ayan.
Yeah. The
Dr.
exception
Coronel.
is rabies, where you really have, if you give it IM.
Dapat talaga pag-aralan yung mabuti. Basahin nyo munang mabuti kung IM or sub-Q yun bago nyo i-inject. Dr. Coronel?
Kung doon sa rabies lang, hindi na yung IM or sub-Q, ID ang importante yung intradermal. If you are not confident giving the intradermal injection, mag-IM ka na lang. But be sure that yung vaccine na ibibigay mo ay pang-IM lang talaga. Because if you are not confident giving your ID, then there's a wastage of vaccine and it may not work at all.
The easy way to remember is, kung IM lang talaga siya, hindi mo pwedeng i-sub-Q. Pero pag sub-Q, pag nagkamali ka na IM mo, okay lang.
Attorney Divina, pwede bang ma-malpractice ang doktor na nagbigay ng IM kung sub-Q dapat yon?
Actually, sabi nga ganon, there's a general provision that in any case of negligence, so if that is a case of negligence, there's always a possibility na pwede ka talagang makasuhan.
Yun nga po ang
So,
sinasabi na.
yun yung laging factor. Is it a case of negligence?
So, kailangan basahing mabuti. Kaya po tayo nagkakaroon ng vaccinology course para nga malaman ng ating mga doktor kung ano ang dapat gawin. Marami pong doktor natin, akala alam na nila lahat tungkol sa bakuna, hindi po totoo yun. Maski po kami, di ba? We always find new things about vaccines. There is no such thing as we know all. In fact, I tell you, this group always argues. They have lots of disagreements in many instances. That's why we need a panel when we discuss about vaccines. Next question. If you have an illness, and you can answer, any one of you, when can you give the next vaccine when the illness occurs? Typhoid. Kailan mo pwedeng magbibigay ka pa ba ulit ng typhoid vaccine? And when? Flu, ang isa, at yung isa, pneumonia. Can you give HIV and pneumo? What interval would you give before you give this vaccine? If you can give the vaccine. Kuha nyo? Okay. Short answers. I'll try to hurry it up. Ang dami pong question dito eh.
Sa typhoid, for example, kung nagka-typhoid ang pasyente in the past, it does not mean that the patient has a lifelong immunity. So if the patient is at high risk of getting another typhoid, then go ahead and give your typhoid vaccine. Because there is no... When the patient is better, convalescent, or even when he's...
Can you give it before discharging the patient?
No.
How long will you wait?
As soon as the patient becomes well. It could be a week.
For typhoid, how
1
long?
month. Depends on the patient. 1 week, 2 months, 1 month.
1 week you can give a typhoid vaccine if the patient wants it.
Post-recovery, yeah.
Oh, any disagreement or any answers? As I said, there are
Same answer for flu and
flu and
remember
pneumonia,
there
HIV
are
and PCV.
There are many strains, many serotypes. So if you get infected with one serotype or one strain, you're not protected against the other, so you can still receive the vaccine.
That's true for flu and pneumonia with HIV and PCV. For typhoid,
Kasi wala namang immunity dyan.
okay,
So, you
so
can give it.
you don't have to
Not right
wait
after
long.
discharge, maybe after 2 weeks.
2 weeks.
1 month.
Dr. Coronel says,
Siguro
maybe 2
naman
weeks.
if you have the typhoid disease, you don't want again to get it. So you have to have the precautions. Importante, you know how to get it. So you have to know how to
Sige, so
avoid
2
it.
weeks. Si elderly queen, senior citizen, pag elderly,
In order to improve the uptake of vaccines for flu and pneumonia, there are studies that show that prior to discharge from the hospital, you can, and it's probably the best time to give your flu or pneumonia vaccine. So, before going home, pa-orderan mo na o ikaw na mismo ang magpabigay ng flu and pneumonia vaccine. There are studies that show that this is not associated with a higher risk of developing or redeveloping pneumonia. And you are sure that the patient that you discharge is now more protected.
that's a good idea, therefore. Ayan, according to the experts, you can give your vaccine even before discharging the patient as once he's well. Whether it is flu, pneumonia, HIV, or PCV for children, agree ba ang ating pediatrician? Even for children, you can even give it before discharging the patient as a gift going home, as a going home gift. No disagreements from our panel? Dr.
No,
Coronel?
especially in the elderly. Because maybe there will be no more time for this patient to develop again pneumonia because he's an elderly, or maybe you will not get back the patient. He will not come back for follow-up. So that's your best time to give it before you discharge your patient.
Ito naman po, tetanus toxoid. If you were given tetanus toxoid and human tetanus immunoglobulin or ATS this month, and you get wounded again, ako, napaka-accident prone. The following month, would you give the same again? 1 month after, nasugatan na naman, magbibigay pa ho ba ulit kayo ng human tetanus immunoglobulin?
Immunoglobulin, maybe not. If you receive
Or
the
tetanus
toxoid
toxoid daw?
a month ago, then maybe what you can do is give the second dose, if it's a primary course, 1 month later. But there's no need to give the immunoglobulin anymore.
Tutuloy na lang, kung 1 month later lang. Kung 1 year later.
You have to clarify if the patient has received the primary 2-dose series or is this a one-time dose, the first time they're going to get? Because if this is the first time they're going to get tetanus, then you have to complete the 3-dose series. And the following month, probably have to give TDAP or T, depends on.
And the 3 doses is 1 month apart.
016. If the patient is...
For tetanus, 016.
Yes. If the patient is fully immunized and you gave a TB or a booster, you don't really need to give any other tetanus toxoid vaccine.
Okay. The next one is how about rabies? Ganun din. Nabigyan na siya ng immune globulin, tapos siguro nakagat na naman ng aso or what is the duration daw of that immune globulin ng rabies? RIG, no? Rabies. Tama ba yung nag-question ito?
If the patient has received immune globulin, you don't have to repeat it.
So, mas kinakagat siya ulit ng aso after 1 month?
1 month after. So, na-complete.
Or 2 months after?
If he has completed his 4 or 5 doses of the vaccine, probably after a month, pag nakagat siya ulit, no need to give immune globulin, but maybe you can give a booster of 2 doses.
Kung 1 year after, nakagat na naman siya ng aso.
Yeah, booster pa rin. Day 0.
Start ka ulit. Start ka ulit kung 1 year after. Kung 1 month, kasi sabi
Patayin
dito
na lang
1
ang
month.
aso. Kasi palagi siya kinakagat.
Meron kong ganon. Laging nakakagat ng aso. What if the patient is under the influence of alcohol? Can we give adult vaccine, as in any adult vaccine? If he is under the influence of alcohol, lasenggo yata. Kung lasenggo or under the
Since we are in rabies,
can we give vaccines for adults?
In rabies, alcoholism or the intake of alcohol means that the patient cannot be given intradermal. You should choose to give intramuscular, just like an immunocompromised patient. So, kailangan intramuscular. But pwede mo bigyan.
Yeah. So alcoholism is not a contraindication
Yeah.
to...
In fact, it is an indication.
Ito kay Dr. Shelley, our senior queen. As we grow older, our immune system goes down too. How could we guarantee our elders that vaccination is still effective when we are administering those vaccines on them? Ibig sabihin, how do you convince the elderly na kaya pa nilang mabakunahan?
Well, vaccine efficacy is quite good. It's not 100%, not for any vaccine for that matter. If you are concerned about the 50 to 60% efficacy rate of a particular vaccine, that's no reason for you to not give that vaccine. Of course, you can consider giving vaccines with adjuvants, but keeping to a good schedule of the best available vaccine in your area is the best strategy pa rin. And don't forget that the bigger problem is not vaccinating the elderly.
Very good. Well said. Ito po, kung kulang yung bakuna, if a vial that you are aspirating from, kulang na ng 0.5, can you get another, let's say 0.2 lang yung nakuha mo, can you get another 0.3 from another vial? In other words, pwede bang paghaluin yung dalawang vial? O multi-dose, like hepatitis B?
Kung multi-dose yung vial, pwede kang mag-aspirate. Pero kung yung single dose lang, bibili ulit siya, mas mahal na. So,
This is in usually the
kailangan kasi
local center
kompleto.
eh. The local center where there are
Local
multiple
center.
doses.
Multi-dose naman.
Pwede bang mag-aspirate ka nung natira na lang? Inubos mo eh, talagang tinipid eh. 0.3 na lang. 0.5 ang kailangan mo. Kukuha ka pa dun sa isang another vial?
Pwede naman.
Pwede
kasi-
bang gawin yun?
Pwede siguro, kasi kulang eh. It should be complete. The
Pwede
full
mong
dose
i-mix,
should be given.
pwede mong i-mix yung dalawang vial. Ayan. Merong, alam nyo sa audience, you can also participate. Yes, doctor. Please, we have, it's nice when you have an audience participation here.
To Dr.
No. Are you
Dr.
answering the question?
No, I'm asking a question.
We are answering the question. Can you mix the two vials to make the 0.5?
Each vial of multi-dose vaccine have different lot numbers and probably expiration dates. So we don't really know what to effect. And if you take 0.3 from that new vial, you'll be missing again a dose. Because if, for example, it's 0.5 and 10 cc, you'll be missing 0.3. So it's again wasted. Yeah.
So your answer is, wag na lang.
Well, it's
Wag na
going to
lang.
be safer.
Kumuha na lang ng bagong
There's
vial.
always-
One vial na lang ang
Yeah, because
source nun.
when you have multi-dose vial, there is always a provision for spillage. That's why for a 10-dose multi-dose vial, sometimes you can only get 9. You don't really consume the whole 10 doses. You won't be able to get 10 doses in a 5 cc 10-dose vial. No, you have to factor in the spillage.
Sige. At saka contamination din, no? Mas mabuti na yung doon ka na lang sa vial na yun. Opo, let's give a chance for your question then.
First, I have a comment and a question. The information is for occupational health workers and for the companies. I'm happy to announce that the Philippine College of Occupational Medicine has listed in the occupational safety and health standard as immunization is listed as one of the mandatory programs, no, in companies. So my question is for Dr. Montalban. We've been talking since 1995 when I was doing my postgraduate course at the UP College of Public Health. The talk of WHO Millennium Goal at the time in 1995. And vaccination is one of the strategies. How effective or how far have we gone? It's now 2012 or 17 years later in implementing vaccination as strategies in public health as a whole. What has changed since 1995 up to the present in this strategy?
As to how effective has been the strategy for vaccination, again, how
Yes,
effective
and,
has it
how
been
far have we gone in the
reaching
Philippines?
the public health arena?
Right.
I think that question should be answered by a DOH person.
Joyce Dukusin just left this
And
morning.
I think it's a work in progress. That is my answer there. No, it's not going to